Okay, first case, limited choices here, so it's gonna be long. 67-year-old who 7 years ago presented with eye pain and headache. At that time at another hospital underwent a craniotomy and radiation. Now presents with diplopia, right eye ptosis, and headache. Again, past medical history, really just this prior craniotomy. Exam, ptosis in the right eye, a minimally reactive pupil in the right, and decreased adduction of the right eye. Has tongue deviation to the right. So what? Just some general thoughts. Long.
Yeah, it sounds like he has a right.
Right. Yeah.
Yeah, like at least a CT and
All right. Sounds good. So here is the sequence of MRIs. These are all contrast T1s. You want to just describe what you're seeing?
yeah, looks like a right neural based medial stimulation lesion invading into the right cavity sinus. That's gonna be right, like most of this looks.
I guess maybe more broadly before saying it's dural based. Intraaxial or extraaxial?
Yeah, looks like that.
Right. Okay. So extraaxial and yeah, I think you described it well. Does it fits the exam? Yes, no, maybe?
Yeah, I think it, no, I think the fits the exam. Fading into the cavity sinus. Outside. It's yeah, so I guess looks like it's hard to see on the roll pictures, but I would imagine it could be invading into this period fissure.
And how does it look different here compared to the prior images? Because they were fine for many years. The far right is a new one. You just like describe the enhancement. It looks a little different, right?
Yeah, so it looks like the enhancement is it looks like there's more enhancement on the left side. There's, I mean, you can see like they sort of pull, like a pull
I mean, the surgery was before this, so just describing this tumor here looks very different than this tumor here.
Yeah.
Right. Right. Yeah, exactly. So here are some other sequences on the bottom. So T2, T1, and then a flare. So T2 hypo intense, flare, sorry, hyper intense, T1 hypo intense. And there you have the other slices of the contrasted scan, as you said, kind of this new modeled intensity or heterogeneous enhancement. So what would be your differential for this? You said one already. What is in favor or against meningioma?
So the fact that it appears like a hypointense, within the lesion now, generally like meningiomas are homogeneously contrast enhancing. I would also consider like a primary like full lesion. Like like chondrosarcoma or chordoma.
Good.
It's not restricted.
I don't have a diffusion here.
So I would say those three.
Yeah, that's good. So just making it even broader. You hit, I think, the big ones. So what would you want to do for this? new symptoms, prior treatment, now new symptoms, enlarging tumor.
Yeah, so I think they have a biopsy.
Yeah, very reasonable. So that's what they had. And we'll go to the pathology slides.
All right. So this is the lesion. Whoever said chondrosarcoma is correct. So this was called chordoma on the very first biopsy or resection, but it is chondrosarcoma. So what you see here is the matrix is kind of hyaline, and you see a lot of cells. And this is higher magnification. So you see the cells hyperchromatic, and there is a terminology that we use in cytology. It's called high nuclear cytoplasmic ratio, meaning the nucleus is large and the cytoplasm is small, which indicates neoplasia. Like all tumor derived from cartilage are S100 positive because cartilage is S100 positive. And brachyury, so this is a true chordoma case, and this is our case. Here you can see some cytoplasmic staining, which doesn't count. Brachyury is a transcription factor, and therefore it's a nuclear stain. So this is how brachyury is supposed to look like in chordoma. So this is a chondrosarcoma grade 2 out of 3.
So chondrosarcoma, the tumor that we described here, pretty classic in presentation, commonly presents with cranial neuropathies, and often located off midline, which is helpful to differentiate it from chordoma. And in terms of the MRI characteristics, as we saw in this patient, T2 hyperintense has this kind of heterogeneous, like modeled enhancement on the contrast enhanced scans, and there's often calcification. As Dr. Saad described the histology, so abundant extracellular matrix, dark nuclei, as he described, in S100 positivity, and then higher cellularity with a myxoid matrix can be seen in the higher grade chondrosarcomas. In terms of treatment, surgery and radiation are the standard of care, and survival obviously decreases with increasing grade. For grade 1 chondrosarcoma is 80 to 90% 5-year survival, and that goes down as the grade goes up. Grade 3 can have a higher rate of local recurrence as well as metastasis. So that's case 1. Case 2, Davik. So this 53-year-old, 6 months of diplopia, dizziness, and gait imbalance. No past medical history, and he's neurologically intact. So you want to describe what you see here? So CP angle, do you think it's extraaxial, intraaxial? What's that? Maybe look at like yeah, so it's intraaxial. Yeah, I guess kind of can be deceiving, but this is intraaxial enhancing, as you said, and yeah. All right, so what would be your differential for this? I'll go back to the images. What would a typical appearance of a hemangioblastoma be? So hemangioblastoma, cystic lesion, enhancing nodule, and a large cystic component. So yeah. All right, yeah. So yeah, basically you hit a lot of them. Had to make it more than 4. I mean, fair, true. All right, so what would you want to do for this, David? Yep, so that's what was done, and there's the pathology.
Okay. So this is the tumor. It's quite cellular, and you see areas of hypercellularity alternating with areas of hypocellularity. And on higher magnification, we know that we're dealing with astrocytoma, since the background is kind of very fibrillary. So that's what you get an astrocytic differentiation. Notice that there is no atypia, well, mild atypia, but there is no necrosis, mitosis, or vascular proliferation, which are the hallmark of high-grade gliomas. And this is just to show you that there is the absence of necrosis and vascular proliferation. So we have a vessel here with very thin wall. Ki-67 is a little bit high for an astrocytoma, maybe 4 or 5%. GFAP is diffusely positive. OLIC2, which is a pan-glial marker, is also positive. So we confirm that we are dealing indeed with a glioma, most likely an astrocytoma. Only 4 or 5 years ago, we used to call this astrocytoma grade 2, and the neurosurgeon will call us back, it's not behaving like grade 2 astrocytoma, please review. And we would review and we'll issue the same diagnosis over and over again. But now we know why. So this is H3K27M, which is one of the 3 histones that we use in neuropathology, and it is diffusely positive. And here you can see very nice negative internal control, which are the endothelial cells and some lymphocytic infiltrate, but the tumor cells are positive. And that's a defining feature of diffuse midline glioma, although by histology is low grade, but since it harbors H3K27M mutation, it is WHO grade 4 because it behaves like a glioblastoma.
Dr. Sadek, run that on every astrocytoma? Like you run that on every astrocytoma?
You do all 3 histones at that place.
Because I wouldn't have guessed that scan.
That's why I'm presenting it. I think it's because it's not necessarily right at the midline. It's cerebellar. It's sort of unusual.
In adult, I'm seeing more and more diffuse midline gliomas that are not midline.
Yeah.
That's supposed to
I
be.
say that.
Yeah.
Yeah, so the classic midline glioma, right? We see them often in children, and similarly present with cranial nerve palsy, cerebellar signs. The markers that are important, really the H3K27 mutation is what's kind of changed the paradigm for these. And as Dr. Saad said, histologically, they appear as low grade. They don't have the classic appearance of a high grade glioma, but they behave more like a high grade glioma. And often can have minimal enhancement and are hypointense on T1. And kind of reviewing what was mentioned, the discovery of this mutation has given us a better understanding of its behavior, and they've even expanded it not to just this mutation, but in the recent WHO guidelines, other alterations at this to this histone seem to behave similarly to this specific H3K27 mutation. So the idea of diffuse intrinsic pontine glioma, that's changing to diffuse midline glioma, and H3K27 altered is the way that it's being described, with a variety of different mutations to this particular histone. And as we said, the molecular features are more important than the histology, which appears low grade. And again, aggressive behavior, poor prognosis in pediatric patients, very poor survival, and in adults can be more variable, but similarly poor prognosis. Management is radiation, chemotherapy, and sometimes Avastin. All right, case 3, Adam, 64-year-old with headache and left facial pain, has a history of diabetes, hypertension, hyperlipidemia, and uterine cancer, and neurologically intact on exam. You want to describe the imaging here?
Yeah, so you see a REM enhancing lesion in the left anterior temporal lobe that is looking at the diffusion restriction seems to be restricting. So epidermoid would be high on my differential for this lesion. other lesions that I could have thought about would have been meningioma, but less likely that would be only rim enhancing. Could have thought about like Mets as ring enhancing lesion. I could have thought about an abscess as well. So now I would think epidermoid and abscess would be the highest on my differential for this right now, given the characteristics of
Yeah, it's a good differential. Do you think it's extraaxial or intraaxial? Just to help narrow it down. I agree. So differential, I think you hit most of it. You know, the diffusion restriction definitely is critical here, as you said. So what would you do for this?
surgery. The patient is already, the symptoms are not, so he's having facial pain. I'm not sure if that's the cause of facial pain. But so I would recommend surgery for sure for her. I would recommend a periodontal and here temporal like I would remove the tumor resection. That would take it away.
And how could you tie it potentially to the facial pain?
So we're thinking about like trigeminal nerve right now. So and the what's the ganglion? So I would have thought that maybe so that if the tumor is extending into the megal state, that would be the so why would it have pain?
Yeah, I think that's a reasonable thought for how it could be presenting here. All right, so yes, temporal cranium for resection, and all right, pathology. Yeah.
Okay, so this is the lesion. Here you can see a lot of keratin flakes and then the squamous epithelium. Underneath it, you have a thick fibrous band. I don't know if it's dura or not. And this is a closer look. So you can see the squamous epithelium with a lot of squamous flakes within the lumen. The only difference between epidermoid cyst, which is this case, and dermoid cyst is that in dermoid cyst, you have skin adnexa at the outer surface, like sebaceous glands, sometimes hair follicles, which are absent in this case. Therefore, this is an epidermoid cyst. And also there is evidence that this cyst has ruptured a little bit before surgery. So here you can see the keratin flakes surrounded by significant inflammatory infiltrate.
Okay, so epidermoid cysts tend to have a slow and linear growth. Presenting symptoms are often cranial nerve palsies due to the mass effect and their location, commonly in the CP angle. In terms of the imaging, mimic CSF on the MRI, but you correctly pointed out that the diffusion was helpful here, and they would restrict on DWI, but otherwise would mimic CSF on the other sequences. And when these cysts do rupture, they can often cause aseptic meningitis. The appearance of them, white pearly appearance, is a classic. Right on the right bottom image, you can see the classic appearance of them. They have this thin capsule of squamous epithelium, and then this kind of waxy contents, which are epithelial keratin and crystals as well. Because of their nature of kind of infiltrating through in the subarachnoid space, infiltrating around kind of the surrounding structures, they can be very large before they actually cause symptoms. Treatment is surgical, and the rate of recurrence is not surprisingly inversely correlated to the extent of resection. So in terms of reintervention within 5 years, if there's a gross total or near total resection, it's basically 0%, whereas subtotal resection about 50%. And even on the recurrence, they often have to recur significantly before they represent with symptoms. All right, so case 4, who else is here? All right, Sumit, 77-year-old man presenting with 1 month of numbness in both of his feet, gradually ascending up his legs. Also reports gait imbalance and urine leakage intermittently. history of diabetes, also with an aortic valve replacement on Eliquis. His exam, he's full strength, has decreased sensation to light touch in both of his legs, diminished reflexes in both of the legs, and normal proprioception. What are you thinking at this point? What kind of imaging would you want? So lumbar MRI was normal. So this is a thoracic MRI. What do you see here?
Interesting.
Like, no hyperflexion.
Correct.
For contrast. Looks like the girl was upper thoracic for.
Yeah, I think that's good. And then in terms of your differential for this? Could it be not neoplastic maybe? Yeah, I agree. I think, it looks neoplastic. The cord is kind of swelling, a little bit swollen at the site of the tumor, enhancing. So you kind of hit a lot of this, a couple extra things, lymphoma, hemangioblastoma, or less likely a MET, but I think you'd kind of hit on the important ones. And so what would you do about it? All right. So yep, that is correct. That's what they did. And here's the pathology.
So this is the lesion at low magnification. You can see that there is a mononuclear inflammatory infiltrate. It is crushed, unfortunately, which limited the histologic evaluation a little bit. And this is higher magnification in a relatively preserved area. And you can see this infiltration by numerous lymphocytes. So these lymphocytes are CD20 positive, which is a B cell marker. And PAX5 highlights some of the cells. PAX5 is a marker of immature B cells. So we know that we're dealing most likely with the neoplastic B cell lymphocytes. So this was called atypical lymphocytic infiltrate, suspicious for B cell lymphoma.
No, hey, thank you for presenting that. Can you hear me?
Yeah.
Yeah, no, it's a bit of an unusual case. I mean, no one should walk away thinking lymphoma is a common diagnosis with spinal cord problems. Extremely rare. When we saw the patient in the clinic, we thought maybe this might even be a transverse myelitis because he presented sort of subacutely, and most ependymomas come chronic. And it has almost like a patchy dorsal enhancement, which is kind of weird for ependymoma. And then as he got worse, we did the surgery. We did several biopsies. I don't know if Dr. Assad wants to address, the issues that come along with trying to do biopsies in the spinal cord. I'll tell you one thing is we now use a sonopet with a aspirator function that will collect all the cells rather than it just going into the garbage, which most of the tumor is removed by the sonopet. But I don't know if Dr. Sad wants any comments about frozen sections, lymphoma, what we should be doing differently.
Well, we all know that the spinal cord biopsies are inherently small, and every time there is a poorly differentiated tumor, B-cell lymphoma is basically a poorly differentiated tumor because of the presence of immature lymphocytes. It's not uncommon to have crush artifact, not because of something wrong you did or something wrong we did. This is common with poorly differentiated tumors. And I thought it's lymphoma, but our hematopathologist wanted to be a little bit careful and not pull the trigger, just call it atypical lymphocytic infiltrate, favor B-cell lymphoma.
Okay, thank you.
It was purely intramedullary.
Yeah, I was there, but that's what I understand. Yeah.
Yeah, it was definitely medullary and have the appearance of ependymoma, whitish, while ependymomas tend to be sort of brownish purplish. And so we ended up treating him with radiation, and he got a little bit better with radiation, I would tell you. Again, favoring lymphoma.
I just want to add one more thing in terms of frozen section. It's, the spinal cord tissue that's not neoplastic, that is around the tumor itself, will often show hypercellularity and reactive gliosis. So if we get a biopsy, not from the lesion, but from the area surrounding the tumor, we most likely will call it low-grade glioma or frozen section because of the reason I just mentioned. So we rely a lot on you guys to tell us whether this is really from the tumor or from the adjacent tumor. So, and thank you for sending another biopsy, because the first one, I was worried about low-grade glioma, but then the second frozen, I was comfortable calling it lymphoma. So communication is very important, and thank you for that.
Yeah, and Dr. Saad, when we use this new net, basically what it is, it's a filter on the sonopet, and it will let liquid go through and it will catch all the cells. And we're getting it in-house hopefully soon. Is there anything that we should do special when we send that?
For frozen, no, but formalin, for permanent, I would put it on formalin right away, just to avoid the degenerative change that are common in these tumors.
Okay, thanks.
All right, so the diagnosis was B-cell lymphoma, which is a non-Hodgkin lymphoma, common in older males. It's a typical demographics. Immunosuppression is a risk factor, but this patient obviously did not have that. And as Dr. Levy was saying, an unusual diagnosis, and for a lymphoma to present in the spinal cord, really only 1 to 2% of these CNS lymphoma presents in the spinal cord. So in terms of the histology, malignant B cells clustered around the perivascular space, typically intermediate to large monomorphic mononuclear cells and prominent nucleoli can be seen. In terms of the markers, these are some of the B cell markers that can be seen, and often accompanied by reactive inflammatory infiltrate. So that's, and Dr. Side went through it very thoroughly. In terms of the treatment, biopsy is important, obviously, and steroids prior to biopsy can diminish the yield of the biopsy. And then methotrexate, rituximab, and steroids in terms of the medical treatment, and then radiation, which can be effective in the short term, as was seen in this patient, but it's usually just a temporizing or palliative measure. In terms of the long-term effectiveness, it can be limited. And then if they're on these immunomodulating medicines, prophylaxis for opportunistic infections is important as well. Prognosis is very poor, with median survival of less than 2 years. So, all right, that's all I have.
Good morning. I am here. Thank you. Sound looks good. Okay. I am here from Karen Zupko and Associates to talk about neurosurgical coding and reimbursement and RVU collection, okay, because everyone's concerned about RVU collection. And we're also concerned about making sure the codes are correct so that they go into the payer claim pays it, and the claim comes back and everybody's happy, the money comes back. So we want to make sure that we're coding accurately. Overcoding or undercoding is not something we want to do. We want to make sure the codes are correct and we get paid correctly. So this is us, Karen Zupgood Associates. We are a consulting firm out of Chicago, Illinois. I've worked with you guys before many years ago, as has Kim Pollock. We're going to look at a few things, and I've had some questions come in that some of you have asked Nansha and that she has let me know. And luckily, one of the first ones is about assistant and co-surgery, okay? And this is a hot topic for our payers, especially for Medicare, who's now auditing use of 62, the co-surgery modifier, and 82, the assistant modifier. And why is Medicare looking at it? Because it pays more. Co-surgery pays more than assistant surgery. So they're looking at the overuse of co-surgery. And how do we overuse it? Well, we overuse it if two neurosurgeons in the same case are billing co-surgeon. Our AANS, Medicare, all of our other payers agree that co-surgery is two surgeons of different specialties doing distinct and separate parts of a single CPT code. Assistant is two neurosurgeons working on a case when there's no qualified resident available, and it's one assisting the other. Yes, doctor.
But there's tremendous amount of subspecialization within neurosurgery. So perhaps you can address.
I can, thank you, because I was going to go there next. As a neurosurgeon, there are no subspecialty categorizations in neurosurgery. We know you might be functional, peds, endovascular, spine, cranial, whatever, but the neurosurgeon is a neurosurgeon to all of your payers. Unfortunately, when you enroll to get paid in your payers, whether it's Medicare or Blue Cross, they ask you when you enroll, what is your specialty? You have one choice, okay? And if you put down neurosurgery or spine neurosurgery or peds neurosurgery, you go into the pot of all neurosurgeons. And from the payer's perspective, you are the same billing provider as the peds neurosurgeon and the endovascular neurosurgeon and the spine neurosurgeon. There is no distinction. So even if you have a peds neuro in with you and you're the adult neuro, and you're doing the case together, it can't be co-surgery. And that's what Medicare is concerned about and other payers, okay? Because the rule is a neurosurgeon is a neurosurgeon. There's not even an endovascular separate category, okay? Same thing with ortho. Ortho has lots of subspecialties. There is ortho, there is hand, that's all, okay? So if you're a neurosurgeon and when you enrolled, you likely said, I'm a neurosurgeon, and that means you go into the pot of all the neurosurgeons, and it doesn't matter if you have a different skill because you do peds or you do endovascular. If you assist or work with another neurosurgeon, you are assistants, okay? And Medicare is clamping down on this because they don't like to pay more money under any circumstances. So when they're seeing that they're paying 9% more, it makes them very antsy, okay? So that's why they're asking all of their payers, all of their MACs. I think you have, is it Palmetto or Florida Coast? Yeah, okay. So you have a MAC, which is Medicare, who administrates here for you in Florida, and they've been told by the OIG, start looking at the overuse of the 62 modifier, the co-surgeon. So if you assist your partners, it's got to be an assistant. Also, we'll talk about endovascular. Who does endovascular here? Nobody? Okay. Endovascular, unfortunately, because they are a catheter-based procedure, and even though you need someone else there to help you with the catheter, whatever, no endovascular codes by Medicare except a co-surgeon or assistant modifier. So even if your partner does assist you in an endovascular procedure, you cannot bill that out to Medicare at least, because Medicare won't pay for an assistant and definitely not a co in an endovascular procedure. Now, private payers might, but then again, then we're billing differently to payers. And many times institutions say, we're going to bill on Medicare rules to everybody because it's the safest, it's the most risk averse, and that's what many institutions do just to make sure that they don't have to think about every case based on who the payer is, but they bill to the lowest common denominator. That's not great, but that's what many institutions have to do to keep themselves sane and to make sure they cover all bases. But Medicare will not pay for an assistant with any endovascular procedures. Yes. Mhm. Yes, that's a very good question. So let's say you're doing an aneurysm, you're doing an open aneurysm, and you have your endovascular colleague come in to do an angiogram. Okay, and hopefully it's a diagnostic study. Sometimes it's after, that's okay. But as long as that person is doing that ephemeral access, advancing the catheter up into the brain, and then doing that angiogram, that's separately billable. Because he or she had to go to a separate location, had to put the catheter in, had to advance it in and do the angiogram. Now, if you do it yourself, if you're the endovascular person and you do an open cranie because it wasn't amenable to endovascular treatment, and then you do an angiogram, you also can bill the open code for the aneurysm and the angiogram that you did from ephemeral access. Okay, so that's billable, luckily. Okay, but co-surgery assistant is not billable. So again, the reason for this is there's a lot of confusion, as you guys also know, that you think that you can bill with an assistant when it's your own specialty and it cannot be done. Now, a big gray area is many institutions have kind of a relationship with their orthopedic surgeon peers, and they do a lot of cases together, especially deformity cases or very complex spine cases, and they may have an orthopedic surgeon come in and work with them. Well, on paper, it looks like a primary and assist because they're all saying, we did this, we did this, we did the fusion, we did the decompression, we did the osteotomies, and then we did the hardware, and they're all doing it together. Or maybe one does one side and the other does the other side. Now, that claim will go into a payer, and they'll pay for it as co-surgeons because orthopods have a different specialty code than you do, so it will get paid, and it's done all the time that way. But the risk there is that if they're both dictating exactly the same activities, it is a primary and assist. So there is a risk there, a minor one, but still a risk that if it's an ortho and neuro doing exactly the same things, I just had a case like this, they're doing exactly the same things together because it was a large deformity case, it's really primary and assist. They're going to get paid for it right away. And the only risk is if they were to get audited, or if they wanted the operative note for any other reason and saw that there were two surgeons doing exactly the same thing, that's not co-surgery. Co-surgery is you asking a vascular or general surgeon to do your exposure for a midline ALIF. That's co-surgery. They're a different specialty. They're doing the exposure for the anterior spine. They leave and go do whatever they want to do. You come in and do the ALIF, and then they come back to close. That's classic co-surgery. ENT coming into a skull base code, doing perhaps an opening, doing a middle fossa case or an anterior fossa case when they're going around the structures that they like, and then you come in, maybe extend the exposure and then go in and resect the tumor. That's classic co-surgery as well. Okay, different specialties. Yes.
Is this specifically when two surgeons are sharing the same billing code?
Same CPT code, exact same CPT code. And when you ask an ENT or a vascular surgeon to come in, or ophthalmologist occasionally, but let's keep it at ENT and vascular surgeons and ENT, when you ask them to come in for a skull base code because you know they're going to go into structures behind the ear or around the ear that you don't like to play with, and you want them to come in and do the exposure, you need to tell them, I'm going to be doing an anterior or middle skull-based, fossa skull-based code. Here's the code you will use. And this is the only code you will use, okay? Because we're co-surgeon on this. And I'm going to go into these structures. Once you help me with the exposure, I'm going into these structures, which means this links to this code. You must bill this code. You can't bill any ENT code that's somewhere around the ears. You are obligated to bill the same code that I'm billing. Now, the only time you get to bill co-surgery on the exposure is if the ENT comes in, makes their exposure here, and then you go and you extend that exposure because you want to get in more into the brain. Then you're co-surgeon on the approach, and then you hit the resection yourself. However, if the ENT does the entire exposure and you don't need any extension, you go in and resect the tumor, that ENT is obligated to use the skull base code for whatever fossa he or she is in, and only that code. They can take the entire code if you didn't have to extend that exposure. If there was enough exposure for you to go in and resect the tumor, then that's fine. He or she gets the exposure, you get the resection. Okay, we're going to get there as we talk about skull base codes a little bit more. Okay, so again, we went through this. This is the description, and you have a little handout if you care to read this. Nacha can share this with you later, but it just shows you that the difference between co-surgeon and assist is essentially it's one CPT code shared by two surgeons of different specialties. That's co-surgery. If it's two surgeons, an extra pair of hands for a complex case, that's an assistant. And as a university center, you would have to always say there was no qualified resident to assist. So my partner, Dr. B, assisted in this case. Doesn't mean the resident can't be there for teaching purposes, but in the clinical judgment of the primary surgeon, the resident didn't yet have the skills to participate in this case. So a partner came in. Yes.
Do that or just split up the code?
And that's a very good point. Okay, so co-surgery, you can split up the codes. With assistant surgery, you have two options. You either have a primary and an assist puts an 82 on every single code that's billable with an assist code, or you can do split up responsibilities, and that's only possible in a spine case. It's never possible to split up things in a cranial case because there's not that many codes. But in a spine case, if you and your partner neurosurgeon, if one does the decompression and the other one does the arthrodesis and the bone grafts, you could each bill your own codes, okay? Now, I don't know how your RVUs are calculated, but from a payer perspective, the person who did the highest valued code is going to get 100% of that RVU, and the person who did the lower valued code is going to get 50% of the RVU and the payment. The payer will figure it out. Even though you're splitting the codes, the reimbursement and RVU impact will likely be exactly the same. Okay, and if you do primary and assist, the primary can bill everything and the assist can just put an 82 and get 16% of every single code that he or she puts the 82 modifier on. Okay, so it's kind of a balance, and you don't know case by case what's going to be better for RVUs. But again, you can split the codes if there's a clear distinction between what one surgeon is doing and what the other surgeon is doing. Okay, that's an option, but you can only be primary and assist if you're the same specialty. Again, that's what I said here in the primary. And what with the world today, payers do everything not to pay us. And one of the most recent things they do, if the primary surgeon doesn't dictate precisely what the assistant did, not just by having their name at the top of the note, not just by saying it was a really complex case, so my partner had to assist, you've got to put at the bottom of the note, my partner assisted with the exposure, with the decompression, with the instrumentation, everything that partner did for the partner to be able to bill with an 82 modifier for all those individual spine codes. Payers are taking money back. They're asking for assistant and primary op notes and saying, hey, the primary did not even mention what the assistant did. How can I possibly pay for the assistant or payer if I don't know what they did? And they take back money. So it's one other sentence at the bottom of the note that says, and that resident doesn't matter, but if you want to bill for the assistant, you've got to say what the assistant did, usually at the bottom of the note. I know it's one more sentence, guys, but it allows us to bill without risk and without the concern that money could be taken back, okay? So Medicare is going to, when it's co-surgery for your ENT partner, they're going to, and again, most private payers follow Medicare rules, they're going to increase the payment by 125%, split it exactly in two, and you each get 62.5% of the increased fee. That's where the 62 modifier comes from. With the primary and assist, the primary gets 100% payment RVUs on all the codes, and the assistant gets 16% of the allowable fee on those codes, okay? And that's just what I said. Okay, this may not concern you, but Medicare continues to reduce payment Congress and your societies averted a 4% reduction in Medicare payment. Now it's a 2% reduction, which really isn't much better, but they continue to decrease payment. Your private payers should not be reducing payment, but you've got to watch and see if they do. There's been a couple changes to spine codes. We've had a significant 5% decrease in discectomy codes, okay? And that was in the work RVU being reduced from about 13 to down to 12. Some of the other codes, ACDF and decompression for stenosis, have increased just slightly. So every year something happens to continue to decrease RVUs and especially payment. This shouldn't impact private payers, but you've got to watch because it could. Telehealth, if you're doing telehealth, Medicare has expanded that for 2 more years. So if you're taking advantage of the telephone telehealth or the other telehealth codes, we still have 2 more years to take advantage of that for patients who don't want to come in for a specific visit. Not for telling them test results or just chatting, but for what is an alternative to an E&M visit. Okay, so spine coding, there are some new codes for artificial disc. We've been getting paid now for the cervical artificial disc, 1 and 2 levels. There was a lumbar artificial disc code. This year, there's a new for the second lumbar. We don't see this a lot. You here at the university might be doing that, but we're seeing mostly cervical artificial discs nationwide. But you now have the option with an FDA approved lumbar artificial disc, and that was new in 2023. And again, this is the lumbar codes themselves. Okay, so and right now we have the option. And there's lots of removal of artificial discs with patients who don't do as well as we hope they would do. So they come in, you remove the disc, and what do? You've got to put an interbody device in, and you wouldn't just take the disc out and leave them like that. You're going to do something to relieve their pain or stenosis. So once you take the artificial disc out, you can bill for removing the disc, and then you can bill a fusion 22554, not the full ACDF code, because you've already decompressed conceivably, and we would hope, but what you're doing is fusing with an interbody device and bone graft, so you can build the removal and the fusion code, the 22554. Right now, Medicare will eventually catch up, on this, and they'll start telling us only bill 1. But right now, if you remove a cervical disc, you can also bill for the fusion at the same level. There are a couple new codes. I don't see this being done a lot. You guys are early adopters, I've heard, so you may be doing this, but intraoperative radiation therapy, anybody doing this? Putting these, so this is a brand new category 3 code. We hesitate to do category 3 codes because they are tracking codes, and they're codes that are not yet used in standard medical practice, may not have FDA approval, and it's kind of a temporary code to see how often it's used. Unfortunately, it's a catch-22 because people don't use it because payers rarely pay for it. They consider it investigational, but it's here if you have the occasion to use it. And there's one for something that I haven't seen used, a posterior vertebral joint replacement. So again, that's a category 3 code. These codes, for those of you who are residents, are not big boy codes. They're not category 1 codes. They're in a special category, and nobody assigns a fee to them. So it gives our payers the option to say, sorry, it's experimental. I'm not going to pay for it. Okay, I'm going to go quickly through spine codes because we had some more specific questions. But when we're talking about spine and cranial codes, they're usually driven by the diagnosis. So your primary diagnosis should be very specific because that's going to lead you and your coders to a code. So first, again, any one of these have their own codes, and then you're going to talk about whatever decompression you did, what fusion you did, if you used any bone grafts, and then if you used an interbody device, and any other services like a microscope or stereotactic navigation. Using the robot, we're now recommending billing the S2900 just under the code that you used. If you're using the robot for any spine for placing pedicle screws, for example, and we haven't seen this paid yet, but we're starting to track to see if any payers are receptive to paying for that. And then in general, when you cross junctions of the spine, you can't build 2 primary codes, as our coders know. We pick where the most work was done. So if the most work was done at the thoracic level, we're going to build a thoracic code. If most was done at the lumbar level, we're going to build a lumbar code. We can't mix and match. We can't do what's called 2 primary codes if you're in one operative session. I'm going to go over quickly just some cervical codes. These are for central patient with cervical myelopathy. You're just doing central laminectomy, no facetectomy, foraminotomy. These are codes for that. Once you do a facetectomy, do any lateral work, you've got a different code. And one of the things that is oftentimes a dilemma for coders and physicians is how do we count laminectomies? And laminectomies for decompression are counted by motion segment or interspace, okay? If you've got an L3, L4 laminectomy, it's one code because you're decompressing the interspace. You're decompressing the nerves that exit from the interspace and decompressing that, and that is one code. It's not by lamina, it's by motion segment or interspace. And motion segment means the two vertebrae, the movement between the two vertebrae, or essentially the interspace. So it's one code. If you do an L4, L5 laminectomy, it's one code, not two codes. And that is oftentimes a big misunderstanding, especially with the decompression codes, because they do say motion segment, and that confuses people that it means two segments, two vertebral segments. It does not. It means a motion segment or an interspace. Discectomies are easy. It's always the interspace because that's where the disc is. And there are different codes for discectomy, again, diagnosis driven. Spinal navigation is a code that can be built separately if you're using spinal navigation to place pedicle screws. However, this does not qualify if you're using an O-arm or an iso-C-arm, or the newest one I've seen now is a COAS that does a 3D spin around the spine. It gets you a 3D rendering, but it doesn't get you a stereotactic view. So in order to build this code, and all the work is done intraoperatively for this code, you have got to take the spin from the O-arm or whatever advanced imaging you're using, upload that to a stereotactic system, and get stereotactic information to place the pedicle screws. That's the only time when the 61783 is billable. Yes.
You have to discuss how much of lamina will be removed.
No, and the old codes for laminectomy in the old days, when the entire lamina was removed for a laminectomy, you remove the whole lamina. Now you remove as little bone as possible to maintain the structure of the spine. It doesn't matter if you say partial laminectomy, if you say a widened foraminotomy with a small portion of the lamina, that's still 63047, a laminectomy for decompression, okay? It's understood that you're not going to take the entire lamina if you don't have to, okay? So no matter how much lamina you take, if the diagnosis is stenosis, it's going to be 63047 per interspace, okay? And it doesn't matter how much you take, okay? So you do, if you have stereotaxis and you have this, that you're loading the O-arm or C-arm data into a brain lab or stealth system, that's what you need to be able to bill 61783. Payers are routinely denying this code. Why? Because many people think that an O-arm or an iso-C-arm spin, because it gives you a 3D rendering, qualifies as stereotaxis. It does not, okay? You have to take that data and put it into a stereotactic system and actually get stereotactic renderings, and then that qualifies in your documentation for a 61713, okay? And cranial navigation is pre-planning, and that's a lot easier. All you got to say is the patient, based on the brain lab trajectories, we've identified our location as here with the neuronavigation system. That's all you've got to say, and that's 61781 for intradural neuronavigation. The spine navigation is a little more difficult because you've got to explain 2 steps: a spin on whatever system you're using, and then loading that data into a named stereotactic system. So actually name the system that you're loading the data in. And this is for placement of pedicle screws. So our coders know it goes right under the code for the instrumentation. So the payer knows, we hope, that it is for the instrumentation and not for the decompression. You don't get paid for neuronavigation in the spine for decompression, but you do get paid for it if you use it for placing pedicle screws. Okay, again, just what I said, example documentation. The images were obtained from the O-arm. We loaded it into the brain lab to obtain stereotactic images, and these were used to guide placement of the pedicle screws. Okay. Corpectomy, just a mention of corpectomies. These are oftentimes either under or over coded. And a corpectomy means at the cervical level that at least 50% of the bone, the corpus, is removed. At the lumbar or thoracic level, it's at least a third. Okay. And one thing we see it whether it's either it's overcoded or undercoded is a single vertebral corpectomy assumes two fusions, one above and one below where you're removing bone. We often see that undercoded because we've taken the bone out and we're putting an expandable cage in that one defect. We oftentimes see that only one fusion code is built. We've got to build a fusion codes based on what used to be there. And what used to be there was two interspaces. So we want to build two fusion codes and get credit for both. If we don't, we're undercoding, getting paid less, getting less RVUs. Okay, so discectomies above and below are always included because you've got to remove the disc in order to clear the space and put your expandable cage. But the fusion is not included, so that can be separately billable. And again, these drive the diagnosis. There are corpectomies for stenosis and fractures. That's one code. There are corpectomies for tumors, for other lesions. That's a higher valued code. So your diagnosis is going to get you the correct code and the correct RVU value because for a neoplasm, a lesion, intra or extradural, there's more RVU associated with that. So your diagnosis has to be clear about what you are using the corpectomy for, because that's going to drive whatever RVU is appropriate. And these are the corpectomies for non-lesion, for just fractures done from an anterior approach, or for stenosis. These are the most common, but of course, as an academic center, use all of these. And again, people ask, where do we have to take the bone from? Well, it is, and there's no pointer here, there's a pointer, that the 50% removal is end plate to end plate, is shown here in the second graph, or 50% horizontally, okay? It's not this, where you take 50% of the above vertebral body and or 25% of the above and 25% of the below. That's an ACDF, okay? The only time we get a corpectomy is if you take end plate to end plate 50% or side to side 50% of the entire vertebral body, or you do a total corpectomy. And it's best to say, I took 100% of the vertebral body, because payers don't understand total, partial, words like that. They want it quantitated. So you should say I took 100% of the C6 body and then did the additional work. But it has to be end plate to end plate in that same vertebral body of which you are billing for a corpectomy, not an ACDF. Okay.
Where someone has an extra vertebral body, and we literally take about a total vertebral body at multiple levels to decompress the esophagus. What would we be doing for that?
There are other codes for that. If we're not treating stenosis or lesions in the spine itself, there are some other codes that start with a 2-2 that are just removing bone itself to relieve pressure, for example, on the esophagus. So you wouldn't use these codes. These are for actual problems with the spine or the spinal nerves, but there are codes for removing parts of the vertebral body for intrinsic other problems, such as somebody after an ACDF can't swallow, and you go in and take some of that vertebral body to relieve that esophagus. Those are different codes. They start with a 2-2. They're just removing portions of the vertebral body for intrinsic problems of the vertebral body themselves, not these codes. Okay. Okay, so just to show you an example of a corpectomy, or this should be 3, 4, 5, sorry to forget that 6. Here's where it shows. So if we're doing a C4 corpectomy, discectomies above and below are included, but again, we have 2 interspaces that have been removed and will be fused from C3 to C5. So we're going to get the 22845 by 4 is for placing the interbody device, which is going to be an expandable device, the bone graft code, and 2 fusions for the C3-4 and for the C4-5. So that's what's oftentimes forgotten. the fusions totally, or making sure that we get two fusions, the primary code and the add-on code. We want to capture all of those RVUs, okay? And then we also get the plate. So once you place the plate, so this is going to be at least 6 or 7 codes for most corpectomy procedures that you do, because it's always going to be 2 fusions, 1 or 2 corpectomy codes, and then more fusions, and then the interbody device, the 22854, the plate 22845, and the bone graft using the patient's own bone, typically the 20936, okay? So lots of RVUs here, lots of revenue from a corpectomy case. Okay, and then if you're doing an extradural lesion at the thoracic level, for example, these codes are higher valued because you're taking more than just bone to relieve pressure on the spinal cord. You're also removing a lesion, okay, either extra or intradural. The extradural pays less than the intradural, RVUs less or more. So you want to be very specific, and you want your coders to know that make sure you go to the correct corpectomy codes for these other pathologies, because they pay more and I get more RVUs, and I like that, okay? So T9 is a different code, 63301, pays more, okay? And if this was done with a thoracic surgeon, it would be a co-surgery. And then again, we'd have a hardware in this particular case, and then we'd have a cage. And in this case, the cage was not used for the purposes of fusion. This was a extradural lesion, so we didn't really fuse it. We just put a cage in for stability. And then we have interbody fusion at T8, T9, and T9, T10. Okay, so we want to make sure we get and capture all of those codes. One of the big problems we have, and I want to get to some of our questions, just the posterior arthrodesis codes. We know that the posterior lateral decompression codes, there's no problem with that. It's not bundled with any of the other things you do typically, but we get into trouble when we do T-lifts, which of course are commonly done. So if you're doing a T-lift or a PLIF, these are the codes, 22630 for just doing a T-lift or a PLIF, 22633 if you're doing a PLIF or T-lift in addition to a posterior lateral fusion. So you're doing an interbody fusion at L3, L4, and then you're doing also posterior lateral by decorticating the transverse processes and laying down bone. Then you get 22630 because you did a combined fusion, an interbody fusion and a posterior lateral fusion. So we get the combined code 22633. We don't get the 22612. That's bundled into our combo code, which Medicare bundled many, many years ago, as they are wont to do. Okay, so what Medicare did a few years ago, it was very nice because these codes, as I put in red, were 22630 without other than decompression. Both codes say doing a interbody discectomy or interbody fusion without decompression. So the intent of that code was to allow you to bill separately for any additional bony work that you did. Well, Medicare didn't like that. They felt that clinically you remove a lot of bone when you do a T-lift or a PLIF, and typically that amount of bone is enough to decompress that interspace of the spine. So they decided to bundle any decompression codes with the T-lift or PLIF codes. That caused quite a bit of fight from AANS, from NAS to Medicare to CPT. And they said, no matter what, we are not going to pay for any decompression because we think there's clinical overlap and you shouldn't get paid for both activities. So what happened? Medicare bundled with disc removal. We always agreed with that, because any T-lift or PLIF is going to remove the disc, because you always remove the disc to place your interbody device. That's a given. That's included and valued in the interbody fusion codes, PLIF or T-lift. What's not included is additional bony work, especially in the lateral recesses, okay? So the disc was reasonable. We always agreed you should have never billed an additional disc code with a T-lift or PLIF. But then they bundled the regular decompression code for stenosis, 63047, which the code said we could bill for. Medicare was adamant they were not going to pay for that. So finally, a compromise was met and a separate code was developed to get a little tiny bit of extra payment in RVUs if you actually did additional bony work. And it had to be in the lateral recesses it had to be a foraminotomy or additional decompression work that you would document very carefully that would support an additional code. And I'll show you what that is. They also bundled the gill procedure with the TLIF or PLIF. So if you do a gill at 4.5 and you also put an interbody device, they're not going to pay for the gill, okay, which we think is unreasonable as well, okay? And they also build laminectomy for neoplasms and non-neoplasms with a TLIF or PLIF. Now, it's not often that you're going to do a TLIF or PLIF with removal of a tumor, with intradural or extradural. But if you do, you cannot bill for the laminectomy for the neoplasm or non-neoplasm. We don't agree with that last one. We say you should bill the resection of the neoplasm or non-neoplastic lesion in addition to the TLIF or PLIF on the occasions that you do both, and put a 59 modifier on that neoplasm code, the non-neoplasm or the cancer, okay? Because that's just unreasonable. However, what do we do with all the other, the gill and the decompression code? Well, they gave us new codes. Medicare finally relented and say, we'll pay you a little bit amount for that additional decompression work. So these are the codes that they allowed to be included in the CPT manual and actually gave like 7 RVUs with if you do it. So these are the codes that you will bill in addition to a TLIF or a PLIF if you do additional bony work. So the key is you've got to document additional bony work. So you clean out the disc space, you repair the end plates, you size your interbody device, but you also then say, and then I went and did a wide foraminotomy for decompression, or I went to the lateral recesses and did further decompression of the spine and the spinal nerves. That kind of language, if you did it, then supports an additional code 63052 at one level, 63053 at the second level. These are unilateral codes. So even if you decompress both sides at the lateral recesses, do wide foraminotomies and decompress those spinal nerves, which is not, it may not have been included in your TLIF procedure, that is reported only once per interspace. If you go to the next adjacent level and also describe lateral decompression, a wide foraminotomy, decompression of the lateral recesses, then you can bill the 63053 in addition for each additional level at which you do a TLIF and additional decompression. So that's going to be the very important keywords, buzzwords about that additional decompression. Last year, 2022.
You know what RVU?
It's about 7.5 RVUs. Okay. It's an add-on code, so it pays less. And the 63047 code would have paid, you'd get half on that. It would probably have paid about 12 or 13. So it's really a pretty, a pretty big cut. But that was the only way Medicare would allow any additional coding. And since Medicare bundled any decompression with the TLIF or PLIF, all the other private payers did the same, which was a considerable decrease in RVUs and revenue. So you want to make sure that's on your coding checklist. Is it now, Serge? Okay. Okay, good. And it has to be, if you docs hopefully are checking off on a coding checklist what codes you think you did, but your coders are not going to code it unless you document that additional decompression. And again, that's going to say, I went to, the lateral and did a widened foraminotomy to decompress the spinal nerves. That would be enough to convince the payer that you did additional bony work in order to support the payment for these additional codes per level, okay? And what we're doing now with the gill procedure, if you do a TLIF or PLIF with a gill procedure, which is oftentimes done as part of the gill procedure. Now, again, you can't bill the gill procedure because it is totally bundled with no way to unbundle it at the same interspace. So we're recommending if you do a gill to then bill the TLIF and one of these codes in addition, because that's your only option. You can't bill the 63012 for a full gill procedure if you do a T-lift at that same interspace, let's say at L4, L5. So your only option to get extra payment is to bill the 63052. So I've run that by the AANS. They agree that's appropriate to bill the 63052 instead of the gill, instead of 63012, in order to get paid at least something for the additional work that you do, taking the pars defect, decompressing the spine at that level. Otherwise, you're going to get paid nothing for that additional work. So make sure that you keep that in mind. But again, you've got to talk about additional decompression because that's what the payers are going to be looking for now. If they ask for your notes, if that's not in your notes and you just willy-nilly bill these add-on codes to get the extra RVUs, they're going to say, you didn't give me enough information. You didn't do enough extra bony work for me to pay you for that. So I'm taking back all the money. So that's got to be documented by you in the body of the note. Okay, and this just explains what we're doing with those. And again, it's by 2022. Also, interbody devices continue to give us a lot of problems. You're all using these with your T-lifts, with your PLIFs, with your corpectomies. We have a couple of choices. This is for ACDF or posterior T-lifts, where we're placing an interbody device, preparing the end plate, sizing it, and placing that interbody device. And this can be for an integrated device, one that has a plate that's meant to go with it, or for just an individual peak cage. Same thing with this, a 22854 is for a corpectomy defect. So this is by diagnosis, this is your interbody device code. 22859 is a code using something in the interspace, not for the purposes of fusion, but to stabilize that particular vertebral body. Where we see this a lot is if you've got an unstable, maybe osteoporotic bone, and you inject cement into that vertebral body, just like a kyphoplasty. You put a cavity in there, you inject some cement into the vertebral body in an open procedure. You can't bill a kyphoplasty because kyphoplasty codes are percutaneous. Can never bill a kyphoplasty code in an open procedure. So if you're putting methyl methacrylate into the vertebral body in a cavity to stabilize that bone, you don't mean to fuse it, but you mean to stabilize it, then we're going to use 22859, never the kyphoplasty codes, because those are percutaneous codes. This code is the code to use. Now, if you put methyl methacrylate around the pedicle screws to stabilize them as part of your surgery, that's never billable. That's included in the instrumentation, never separately billable. But if you put it in the vertebral body and you say the bone is unstable, osteoporotic, I'm going to put a cavity in here and fill that up with cement, that gets you this code, the 22859. Now, again, you don't bill it with kyphoplasty. You don't bill it if you just put the cement in the pedicle screws. Again, these interbody devices continue to be problematic, denied by payers, because the integrated devices are one code, just the interbody device. I don't know how many of you are using the integrated devices. They're the interbody with a plate that's intended to go with that interbody device. That's called an integrated device. It might have buttress screws above and below to stabilize it in the interspace. That's an integrated code, and all you use is one of these interbody device codes. You can't bill a separate plate because you didn't put a separate plate. The plate was meant to be used to stabilize that interbody device. The problems with this is payers have gotten very, very creative. Vendors, have gotten very, very creative in describing their integrated devices. It used to be very clear if we Googled them that this was a plate that went only with this interbody device. The vendors got wind of the fact that surgeons could not bill the interbody device and the separate plate if these were meant to go together. So they separated the plate, even though it could not be used separately in another surgery as an individual separate plate. It was intended to go only with this interbody device. They are very creative in the way they Google this, the way they describe it. But so you've got to be very careful in making sure that if you place an integrated device that has a plate that was meant to go with this device and only with this device, if you couldn't take it to your next surgery and use it as a standalone plate, that means it's an integrated device and you only bill for the integrated device. You don't bill for the separate plate. So in your documentation, be very clear. I sized, I prepared the end space, the end plates, I sized the interbody device, placed the interbody device. Then I took a separate Medtronic or whatever kind of plate and placed that with screws at C3 and C5 to be clear that this was a separate plate. Best advice is to put the brand name of the device in your note. And it used to be okay because we as coders could Google that and it'd be very clear from the Google picture that these were meant to be used together. But as I said, vendors have gotten very creative because they want to convince you to use their devices. So they'll say, yes, these are separate because they've made them separate, but they're only intended to be used together. So that means they can only be billed as an integrated device, which means you only bill for the interbody device, not for the separate plate, which gets another 20 RVUs. Okay, so be very careful about that because payers are routinely denying these codes to force you to submit your operative note so they can pick out and ferret out whether it was a truly separate device or an integrated device. Again, fractures, there's open fractures. There's only one for anterior. All fractures, most that you do in the vertebral bodies are posterior fractures. And the thing with our fractures, they're for traumatic fractures only. We don't use these ORIF codes for spondylolisthesis or osteoporotic fractures. They're only done for traumatic fractures, okay? If you do it for any other pathology, we're going to use regular laminectomy code, regular ACDF code, regular corpectomy codes. These have to be traumatic acute fractures, okay? And you must remove bone or unlock facets. If you're able to reduce a fracture with instrumentation alone, AANS says you bill the instrumentation only. In order to bill a fracture code and ORIF, in addition to the instrumentation, you have to do some bony work. You've got to actually take bony fragments that were fractured and remove those. You've got to do a full laminectomy to release that fracture from the spinal cord, or you have to unlock drill down jumped facets. Has to be bony work. If you don't need any bony work, and you can reduce that fracture with screws and rods, you're only going to bill for the screws and the rods, okay? That's a very important point. And these are only posterior codes. If you treat a fracture from an anterior approach, it's going to be either a corpectomy or an ACDF, okay? It's not going to be one of these codes unless it's an odontoid fracture. That's the only anterior approach fracture we have. Do you have a question about that? You look curious, okay. All right, so osteotomies is a big deal. I'm going to go over these quickly, but osteotomy codes became very popular among neurosurgeons all over the country when Medicare bundled decompression codes with T-lifts all over the country. And I'm sure you guys did not do this, but all over the country, other neurosurgeons decided the only way I'm going to get paid for the extra work is to bill an osteotomy code instead of a laminectomy code, because Medicare didn't bundle osteotomy codes with the T-lift or PLIF. Why? Because those aren't decompression codes, those are deformity codes. So there was a huge increase in osteotomy codes when osteotomies were not being done. So now the payers are on alert and they may ask for your notes. So how do you bill an osteotomy code? You can't just say I did a Ponte or a Smith-Peterson or a PSO, but you've got to describe the work that it took at each interspace to remove that bone, to correct the deformity at each level for it to qualify as an osteotomy, because the payers are looking. And if you do a 3-level osteotomy, for a 42-degree curve, you've got to describe the osteotomy at every interspace, what bone was removed, what you had to do to correct that deformity. You can't just say, I did a Ponte at 3 levels. That will not fly with the payers. You've got to describe the work you did, the wedge you took, what you did to correct that deformity, okay? And these, because payers are watching for these. And also a big risk is these are the arthrodesis codes for adolescents, for idiopathic adolescent scoliosis. That's when they're used. You guys, unless you're pediatric, most of these are done by orthopedic surgeons who work with peds. The payers would like to pay us for these arthrodesis codes with our adult deformity codes, and that becomes a problem. So if you've got an adult deformity code that you're correcting, maybe with an orthopedic colleague or yourself, so you're doing a deformity procedure with osteotomies that are well documented, and we think with the adult deformities, you should bill a regular arthrodesis code, the 22612, 22610, thoracic for that fusion, and for each interspace, it could be 10, 11, 9 interspaces of fusion codes. Payers like to say, no, use these codes because they're by the number of levels, and they pay a lot less. So they may convert you to an adolescent idiopathic fusion code when the AANS and CPT says you should be able to build the adult fusion codes, the 22612, 22610. So again, these are an audit target. Deformity's got to be the primary diagnosis. You've got to describe the curve before and after, and it's not enough to say I did an SPO or a Ponte, and you've got to document exactly what the deformity was pre and post surgery, and arthrodesis codes are the issue. We say NAS and AANS says you use the regular adult arthrodesis codes, first level and each additional level. The payers say, no, you got to use those adolescent codes because they pay less. So if they convert them, send them back, deny them, you're going to go back with a CPT assistant note that says, no, adolescent deformities have flexible spines. They're the ones for which these fusion codes were designed. For adult deformity with a more rigid spine, you have to do fusions more meticulously at every interspace, and therefore you bill for the regular arthrodesis codes, the 22610 for thoracic, the 22612 for lumbar. So this is a very common ploy on the part of our payers to send it back and say, wait a minute, it was a deformity, you've got to use the deformity codes. And now you have, and I'll send this is in the book for you, a CPT assistant that said, no, flexible idiopathic adolescent deformities are these 2H 7 to 12 vertebral segments. But if we're in an adult with a more rigid spine, such as some adult deformity, degenerative deformity, then you use the regular fusion codes, which pays much, much more appropriately for the work that is done. Okay, so they may kick it back, but you're going to fight for that and get it paid. Okay, so here's the CPT, and it's in your book for you. Okay, exploration. I'm going to skip over some of these, and I don't know what time it is, but 8:36. Thank you. But I want to get to some of the questions that were asked. Exploration of fusion. I don't know how much you're using these codes, but there's a code that says exploration of fusion. Okay, this is probably rarely going to be used by you. Here's the code. And everyone thinks that, okay, whenever I go in for revision surgery, the patient has a new ACDF at an adjacent level, at the same level, the patient's got new stenosis, new disc at the same or adjacent level. I'm going to go in again, I'm going to explore the old fusion, and I get to bill this code. That is definitely wrong. The only time you get to bill for exploration of spinal fusion is when there's a suspicion of pseudoarthrosis. You think there might be, it hasn't been confirmed on imaging. So you're going in to evaluate whether or not there is pseudoarthrosis. And to evaluate that pseudoarthrosis, you're going to take the hardware off, you're going to decorticate that part of the fusion, and then you're going to make a decision whether it's okay and I just leave it, put the hardware back on, or whether I'm going to refuse that particular area of the spine. Once you refuse that area of the spine, there is a huge clinical overlap because the exploration requires taking the hardware off and decorticating. The new fusion requires taking the hardware off, decorticating, laying down new bone graft. So the AANS, even though CPT suggests both the exploration and new fusion may be billed, AANS says don't do it because the clinical overlap is too much. Medicare bundles it anyway. So if your institution is going by Medicare rules, it would not be an option for you as well. But if it's at the same area and maybe just an adjacent level or incorporating the old level, we're never going to bill for it because the clinical work is the same. So it's going to be used very rarely, only when you go in for, you think there might be pseudoarthrosis, You decorticate a little, put the hardware back on, and you don't need to do any new fusion. That's going to be few and far between, right? Because by the time you go in, there's some symptoms. You know you're going to have to take the hardware off, refuse, re-instrument. That's a new instrumentation and a new fusion, not exploration. Okay, so very rarely used in neurosurgery. And removal of hardware. Now, if you remove hardware at the exact same location or revise it, take out a screw, put a new screw in different size, that's 22849. If you remove instrumentation and then you place instrumentation in any level that overlaps the old hardware, you can only bill for the new instrumentation. These codes were developed years ago when we removed hardware for someone who had infection, who was skinny and could feel the hardware. We went in and took out the rods and screws. We didn't do anything else, okay? That's the only time these are appropriate. Now, if you go in for a revision surgery, and I know that you guys are doing, and ladies are doing revision surgery on not only patients that are in their 60s, but patients that are in their 80s these days. So if you're doing a new surgery for adjacent segment disease or re-disc or re-whatever or re-ACDF, if you remove the hardware and put it back in any level that overlaps, you only bill the new hardware, okay? So that's a very definite CPT requirement on that. Okay, just to mention, if you're doing SI joint fusion, there is a new code. Again, it's a category 3 code, so no one's going to really do it. Typically, you're doing it either percutaneous with that device, the iFix or whatever it is. That's a PERC code where you're doing it by fluoro. The open code is only used when you open up the entire joint, you have everything that you're visualizing, and then you put in your screws. The screws are included, not separately billed. So people, I'm sure not you, but are trying to build the open code when essentially they're doing the percutaneous. So make sure that you're documenting this correctly. Okay, before we move on from spine, I want to make sure that I got there's more questions in endovascular and cranial. So let's move on to that. And cranial coding is, again, diagnosis driven. So that's very important to have the right diagnosis code. And there's also lots of things we can bill separately. But a cranial code is going to have a lot fewer codes than a spine code is, because we just don't do that much when we're working in the brain. Okay, but all of these are potential add-on codes. Harvesting graft from another area. Well, of course, you're doing a lot. You're in the brain, for God's sakes. But by the number of codes, you're in the brain. You're doing a lot. But in the brain, unfortunately, we typically have maybe 3 codes, okay? We have the resection, the treatment, we have the microscope, we have neuronavigation. If we have to repair the dura and go to the belly or the thigh to get fascia or fat to repair the dura, that's going to be another code. If we put a subdural drain in because we want further cerebral decompression, that's going to be another code. But we're not going to have 7 or 8 codes like we have traditionally with a very complex spine procedure, but we will have. So you do mostly cranial, doctor? Okay, so we'll have 3 or 4, okay, but it's not going to be 7 or 8. But they're very important codes because we're in the brain, okay? But these are the codes that we can bill separately. The microscope, which is rarely billable in the spine, Medicare bundles the microscope in most of our classic everyday spine codes, like the ACDF, decompression for stenosis and disc. We can build a microscope with corpectomies always in the spine, but in the brain, microscopes are always separately billable, as is neuronavigation and is whatever you're treating for the resection or whatever. Did you have a question? Or are you stretching? Okay, thank you. Okay, and then lumbar drain. Do you have intraoperative MRI here at university? Okay, if you're doing an intraoperative MRI for the specific reason of looking at the resection cavity to make sure that you've gotten all the tumor, you can bill for the intraoperative MRI. It's specifically, this code is specifically for evaluating the extent of your resection to make sure you got everything. Now, conversely, if you used ultrasound to look at that resection cavity and make sure you got everything out, that's not separately billable because that's considered what you do to be a good doctor, okay? If you do anything else, a CUSA or anything else, those are all just what you do to be a good cranial doctor. But if you use an intraoperative MRI to evaluate the resection cavity, that is separately billable. Very few centers have intraoperative MRI, but if you do, you can bill that for looking at the tumor cavity and the margins. Also, if you're doing any awake cortical mapping, so you've got a patient, any other neuronavigation, any other neuromonitoring that you do, whether it's for spine or cranial, is always included in your primary treatment code, because you're either operating or you're monitoring. You can't do both. So if you're doing SSEPs or EMGs or anything else, EEGs for a cranial procedure, they're not separately billable. They're part of what you do to be a good doctor, to make sure that you're not injuring any nerves in the course of your spine or cranial procedure. But a lumbar drain, harvest of graft can be separately reported. Lit therapy, are you doing lit therapy? This is new in 2022, and this is for epilepsy or tumor resections. We finally have codes, but these are, the first code is for a simple lesion or a single trajectory. The second code is for multiple trajectories or complex lesions. But these have a 0-day global, which is unique in neurosurgery. So if you're doing lit on somebody and you see them the next day for an E&M, you can bill the E&M. They only have a 0-day global, which is unique in all of brain surgeries. In most of them, you're going to be stuck in a 90-day global and won't be able to bill for any postoperative care. This has a 0-day global, so all postoperative care in hospital, usually out of hospital, can be billed separately. And this just describes, everything, this code is an all-inclusive code. It includes the head frame if you're using it, any neuronavigation, the intraoperative MRI, anything you do is included in this one all-inclusive code for the simple or the complex. And if you biopsy at the same session, that is included in the lit code. Now, skull base, I had a couple questions on skull base codes that came to me prior to this day. So the skull base codes are, again, by FASA. There's an approach code, that's the exposure code, and then there's a definitive procedure code, that's the resection code. These codes are intended for tumors. They're not intended for aneurysms. They're not intended for CP angle tumors, because they have their own codes, which pay very well, and they're specific for those two pathologies. These are only for tumors other than CP angle tumors. And if you're truly doing a skull base exposure and a skull base treatment. Plus, we can't mix and match. You can't do a skull based approach for an aneurysm and then bill an aneurysm code. Okay. You have to bill, and you can't bill skull based for aneurysms. So for the aneurysms, you're going to bill one code. And when it comes down to RVUs, when you look at the complex aneurysm codes, they pay almost the same as an approach and definitive tumor resection skull base code, because they're very highly valued. So if you're worried about the RVU or reimbursement impact, it's going to be a wash. And we don't use the skull base codes for vascular abnormalities or for CP angle tumors. Okay, so these are the codes we use, and also the 61618 and the 61619 for repairing the dura, either from a free tissue graft or actually taking a vascularized pedicle graft, is never billable during the procedure itself. Any flaps you do, any dural repair you do during a skull base case is always included. The only time you get to bill for repairing the dura after a skull base case is if the patient has a CSF leak after the surgery. So maybe later that day, maybe the next day, you identify that there's a CSF leak, you take them back to the OR. That's when the 61618 and the 61619 come into play. Never, never, never at the same session as a skull base procedure. Okay, so these are the codes: anterior, middle, and posterior fossa. Now, these are paired codes, as I said, and the diagnosis is tumor. It's not vascular abnormality. It is not a CP angle tumor. It's any other type of tumor, okay? These are the anterior codes. And again, the most popular ones I have bolded. And luckily, there's only one resection code. So once we land on the skull base exposure code, the only available treatment code is the 61601 in the anterior fossa. And the most common ones are the orbital cranial approach, where we're drilling down the supraorbital ridge or rim, or the orbital transzygomatic, where you're drilling down the zygoma. So you have to actually, for the anterior fossa, actually drill into bones of the face to show and prove that you're actually going to a skull-based lesion, not just doing a very low craniotomy, but actually having to remove or drill down bones of the face to get to the skull base, lifting up the temporal frontal lobes, whatever, in order to access the base of the skull and remove the tumor. Okay, so that's very important in your documentation for the coders to know it's truly a skull-based code. The middle codes, the most common is the orbital cranial zygomatic approach. Again, we're doing the orbital cranial and drilling into zygoma, and it's talking about at least some of these structures that you're going through. Doesn't have to be every single one, but we look for the key words in the exposure, and then we know we only have one choice for the resection, and that is the 61608, because as neurosurgeons, you're always going to be doing an intradural resection. So even though the exposure might be extradural, you're going to come in, open the dura, and you're going to resect that tumor that's intradural. So we're going to pick the most appropriate exposure code, and then we're going to use the only available intradural code for the treatment code. If you, again, as I mentioned earlier, if ENT is working with you, if you called an ENT surgeon to come in and do the exposure for you, they have to bill a skull-based code. They can't just go to the ENT codes and bill the ENT codes that they know and love, okay? That would be double billing and could really impact your ability to bill your own codes. So you've got to tell them before the case, here's what we're going to do, here's what I need you to do in terms of opening the anterior or middle fossa. And once you make that exposure for me, I'm going to go in and resect the tumor. Your code will be X, and you tell them specifically what you consider their code might be. So it might be the 61592 if they're in the middle fossa. It might be some of these transcoccular or transtemporal code or far lateral codes when they're going behind the ear and they're opening both the neck and the ear, and then you're going in to resect the posterior fossa tumor. They should never be billing their own ENT codes, because if they get their claim in before you do, they'll get paid and you won't get paid, okay? And your coders will have to go in and convince the ENT practice to go in and readjust their claim and get less money. And then for you to go in with them being the approach surgeon and you being the resection surgeon. Now, in other scenarios, if they do the resection in their area of skill set, and you've got to extend that exposure because you want to get farther up into the cranium, you get to be co-surgeon on that approach. And that's got to be made clear to the ENT. I want you back here to get through all the ear structures, but then I'm going to extend that exposure to get to where I want to go. So we're going to share that exposure code. You and I are going to be co-surgeons. So you need to put a 62 modifier on this code that we're going to use in the posterior fossa. And then you will use the resection code all by yourself. Now, if you need the ENT because the tumor is wrapped around some of the structures that is more familiar under an ENT skill set, he or she may also help you with the resection. Then what happens? Your co-surgeons on the approach because you extended the approach, and your co-surgeons on the resection because you wanted the ENT there to work around the structures of the ear that you don't want to mess with, okay? So it really depends on who does what, but you've got to make sure that you let the ENT or other partner know exactly what codes you are likely to bill, and that they have to go in either as the only exposure surgeon or as the co-exposure surgeon with you. Did you have a question back there? Answered it? Okay. So it's very important for you to say, if you go in there and ENT has made an exposure and you've got to extend that exposure to access what you want in the brain, you get a co-surgeon on the approach. We don't want to lose that money. The ENT might not be happy with that, but they're still going to get the 62 on that approach. They cannot build their own codes, okay? And then if they help you with the resection, because there's some of that tumor wrapped around something that's in their purview, then you're going to tell them, hey, describe this, I'll describe what you did, and you'll get a co-surgeon on the exposure, the resection code as well. Okay, so there's got to be communication, and you've got to tell them what the codes are going to be. Otherwise, they may submit a code before you, get paid for everything, and then when your claim goes in, the payer said, I already paid for this patient for this day. I'm not paying anything else because I paid the ENT already. So you've got to be very careful, because that will happen if you're not doing this. So, and this is the secondary codes only if the patient comes back later at a different operative session, either that day or the second day or the third day, where there's a CSF leak that is noticed. You take them back to the OR after a skull-based surgery, and either you do a fairly simple, just a dural repair, or you've got to actually do a vascularized flap, a muscle flap to repair that. That's the higher valued code, 61619. Okay. Okay, we talked about that in the angiograms during an aneurysm. Okay, again, one thing important about skull beds, they're not intended for CP angle codes. We know that when you're doing a CP angle resection, you are actually working in the base of the skull. That's where the CP angle code is. However, the tumor is. However, the CP angle codes predated the skull-based codes, and you have to use a CP angle code if the tumor is at the CP angle. It could be a schwannoma, a meningioma, it could be whatever, acoustic neuroma, but as long as it's a CP angle tumor, you cannot use a skull-based code, even though you're essentially doing a skull-based procedure. So, and you don't use it for aneurysms. I don't care where the aneurysm is. I don't care if it's a really tough basilar aneurysm that really takes you going into the posterior skull base. You have to use the posterior aneurysm codes, and that will pay you as much as billing the skull base codes. And payment's not the issue. It would be inappropriate to bill a skull base code for an aneurysm clipping. Okay. So again, it's intended for tumors only. Okay. Well, the CP angle tumor predated the skull base codes, and it has a lot of value. So if you take the skull base codes and you let's say you build both yourself. So you build the approach code and you build the resection codes. We're going to get a 50% reduction on the resection codes. The total of that is usually about 90 RVUs. A complex CP angle tumor has about the same RVUs. Okay, so there's no difference in the RVUs, and we don't play around with codes in this environment. If we went in, and there's no reason to, the CP angle codes are specific for CP angle. They were valued to take into account that you're going into the posterior fossa. It's a very detailed operation. You may even leave the bone flap off sometimes. You may have to repair the dura. It's all been valued in the CP angle code. So why mess with it? Okay. It gets you enough value. It's specific for CP angle codes. Your ACS and CPT do not want to go in and change codes unless there's a really compelling reason. Because if they did, if they had the chance, they would decrease all codes. If we say, would you please relook at the CP angle tumor codes and put them in the skull base codes, they'd look at all the codes, and the likely result would be they decrease the value on all codes. So the CP angle codes are great. They pay a lot of money. They're specific to the CP angle resection, and there's no reason to change them. Okay, so we can't use them for that. If we're doing an extended endonasal skull base removal of a tumor that's not a pituitary tumor, you have to go unlisted. There is no code to go for an endonasal, extended endonasal endoscopic approach to a skull base tumor that is not a pituitary tumor, like a clival tumor. That has to go unlisted. You can't use the open skull base codes. You can't use that low valued pituitary code. You have to use these codes, 6999, not 64999 for the neurosurgeons, and you could throw in the neuronavigation, and you could throw in if you did a lumbar drain, that's also additional. And then ENT could build their own ENT code, and then you'd build both of these to the payers, describing that you did an extended endonasal approach to a non-pituitary skull-based tumor. Most payers have a fee for this at that stage. This has been going on for over 10 years, using this different approach rather than going through the bones of the sinuses. The surgeons choose to go endonasal, endoscopic to get that clival tumor, for example. So we use the enlisted code. And to your question, Doctor, and there was some movement amidst some nasty rumors, an urban legend, that somebody wanted to develop a code for this particular procedure that's become very popular and common for tumors at the base of the skull that are not pituitary tumors, that are more easily accessed through an endonasal endoscopic approach. If that was done, Medicare would love that, because now they're paying what's consistent with the skull-based codes for that particular endonasal endoscopic code. If we said, hey, we want a separate code for that new procedure, they would take it, they would lump it into the other neuroendoscopic codes that pay much less than the skull-based codes. So in the long run, they'd reduce this payment that has already been pretty well paid by most payers, and they would decrease that code significantly. Okay, so hopefully that has been tabled for the people who wanted to push for a new code, because that puts at risk the value that's now being paid for this code. Usually we ask you to, again, use an enlisted code that's comparable to 61601, much higher than any endoscopic code that Medicare would force us to reduce it to. And for the ENT, they get to a co-surgery on doing the endoscopic endonasal approach, and then they get the 61583. So it's much higher valued the way payers have agreed to value it. It would go into the neuroendoscopic code set, for which there are only 6 codes, and they pay 30 or 40 RVUs compared to about 90 RVUs for what people are getting using this unlisted code for the extended endonasal endoscopic approach. So we have to pray that those people who want a new code have realized that that is the unfavorable result of what they're trying to do, and they put a stop to that. Okay, everything is a snowballing effect in the world of CPT codes. If you ask for a new CPT code, Medicare is intimately involved in the process of CPT codes. They sit at the specialty CPT meetings, and they oversee and overhear anything. And when they find a chance to revalue other codes and devalue them, they jump on that. And the result is lower payment for everything, and then lower payment for the code you're trying to change. So it's a very, very tricky situation. Okay, so this is what we recommend for that extended endonasal skull-based code for other than a pituitary tumor resection. And these are the CP angle tumors. This is what we use. We know it's at the skull base, but they pay very well, and they're specific for CP angle tumors. It could be a meningioma, et cetera. And again, we get to report all these additional codes for that, whether it's a fat graft or a fasciolata graft, a lumbar drain, a microscope, whatever you use, all of those are additionally billed. So I don't want to say there's only 3 codes. We might get 5 codes if we needed a graft from belly fat, or if we needed to put a lumbar drain, all of those additional ancillary things, because you're going to a separate location, make an incision in the belly to get fat, or make an incision in the back to put a lumbar drain. Those are all separately reportable and payable by all of our payers, okay? Microscope as well, and neuronavigation, all of these things can be separately payable. And with a CP angle tumor, if you want to do a ventricular catheter, it's always going to be at a different location. So you're going to put a frontal ventricular catheter in. So right there, we've got almost 5 codes. If we used all of these in a CP angle code, all of these could be separately billable and payable. Anytime you put a ventricular catheter in a cranial procedure, if you put it in the same exposure, it's not separately billable. That's what you do to decompress the brain in your craniotomy exposure. If you have to go to a separate location, do a new burr hole, place a ventricular catheter in a separate burr hole, then you get to bill it separately because you had to do a separate incision to place that ventricular catheter. So all these things can be separately billable in a cranial procedure. Craniotomy for aneurysm, also very highly valued codes. They would pay you more for a complex vertebral aneurysm than a skull-based posterior procedure. These are the pituitary tumor codes. Most common one is the neuroendoscopic code. Here's what we see sometimes with the ENTs who love to build their own codes because they know their codes very well. And this is an example of an ENT who decided to bill all of these codes under a transoral report approach for a skull-based code, a septoplasty, a sphenosynostomy. All of these codes were actually billed by an ENT surgeon when he participated with the neurosurgeon in excision of a pituitary tumor using a transnasal endoscopic approach. That procedure has one code, 61548, and that's all she wrote, okay? When you have an ENT to do that endoscopic portion, they get you in, and when they get you out, they repair the septum, and anything they do is included in the value of 61548. They can't bill any other codes. So it's your responsibility as the surgeon to let your ENT colleague know, I'm going to bill the 61548. That includes everything you and I do. The endoscope to get me there, I go in and do the resection, and then you repair the septum. Once we leave, all of that's included and valued in this very lowly valued code, but nevertheless, it's all valued in 61548. So the only thing that would be appropriate to bill is that code. And if the neurosurgeon went to get fat front, made an incision in the belly and got abdominal fat to again repair the septum, the neurosurgeon could bill for that. Now, if the ENT, while you're doing the resection, they do the incision in the belly and get the abdominal fat, and they place it to repair the septum, they would bill for the harvest of that fat, because we're billing for the harvest of that fat, not for the placement of it. Okay, so whoever goes and harvests it gets to bill for it. But typically in an endoscopic endonasal approach, microscopes included, the endoscopes included, all these other repairs are included in that one little all-inclusive code, with the exception of getting a graft. And this is a fasciolateral graft. It would be 15798 if we went to the abdomen and got fat to do that septoplasty. Okay. And again, it's very important. If this ENT put in all of this information and they were better at getting their codes into the payer than you were, guess who's going to get paid? The ENT. And when your claim hits the payer, they're going to say, sorry, we already paid for that from Dr. ENT, so we're not going to pay twice for that same procedure. Yes.
For the 61548, you and the surgeon both bill 62 modifiers for that?
Sure. If there was something that was more extensive involved in that, but if it's a typical transnasal endoscopic pituitary resection, you'd have to convince me that there was something completely different that took more additional time to warrant and support a 22 modifier. Now, we think that even in an academic center, the 22 modifier for increased procedural services should be used very judiciously. And I'm thinking about 2%, no more than that, again, and that enhances your chances of getting paid. But if you want to get paid, it has to be a much longer, much more intense, complex procedure. And you would have to put a paragraph, complexity paragraph, and describe what about this procedure took me longer, in minutes, in hours, what anatomically was different that made me have to do a more extended approach. But just because it was a regular 61548, I would not see a reason for a 22. Absolutely. I'm sorry. A 62, you would both place a 62. And again, you'd split the value, the increased value of the code. Okay. Endovascular, we had a couple questions on this. The aneurysms are the angiograms are the same, and angiograms are separately reportable with an intervention if there is no adequate angiogram available to you. And again, these codes are the same codes. At risk today, the 61624 for embolization is being reviewed by Medicare. All of our other codes like thrombectomy and non-thrombolytic infusion have been bundled by Medicare. 61624 is at risk of being bundled, so take advantage of it now. And if you if you're doing any venous, I wanted to mention the venous. I want to make sure I haven't missed anything for the endovascular. So these are the same codes, but at risk is our 61624. And again, if endovascular you're using pipeline stents are an embolization device. And I understand that someone might think in your compliance department that those are stents and you can't use them. Make sure you call them a pipeline endovascular device. If you're using a stent just to buttress the aneurysm, so we don't get it, coming out, that stent is never separately billable. Only the embolization is billable. So again, a neuroform stent or any other stent that you use to buttress the aneurysm is not billable. You'll just bill the 61624 for the embolization. If you use a pipeline stent for embolization, that's an embolization device and is billed as 61624. The biggest thing going in neuroendovascular is the increase in venous procedures in the brain. Okay, if you're doing venous procedures in the vein, for example, venous stenting for intracranial hypertension, that's the most common reason to do a stent in the venous system in the brain. There's no code for that. It has to be an unlisted code. That's 64999. We can't use the peripheral code. We can't use the arterial code. That's specifically for atherosclerosis. You have to use an unlisted code. Many of you endovascularly are doing endovascular stenting. You can bill for the catheterization code. You can bill for the venogram. The venogram also includes pressure measurements, but you can't bill for any other code. It's got to go unlisted. Okay. I was going to do E&M, but we ran over time. So thank you guys for your attention. Okay. And any questions before we leave, because it is 9:11 and we started at 8, as long as this the time is correct. Any questions? Anybody doing endovascular?
Sorry, I do have a question.
Yes.
For the CPD codes, what is the limitation on an intraoperative MRI? Does it still have to be in drapes or anything, or before they leave the OR, they can get an intraoperative MRI?
It has to be in the OR, and it must be for the specific reason of a tumor resection. Can't be a follow-up code to look for bleeding or whatever. It has to be specifically because I want to evaluate the resection of the tumor cavity to make sure I got all the tumor. Okay, any other reason, it's included. Yes.
Part of stenting, that be billed as an embolization for covered stenting, or is that a separate stenting code?
So where are you doing it?
For like extracranial circulation for carotid, for tumor development.
Yeah, so you're embolizing the vascular supply to a tumor or the vascular supply to a subdural hematoma. Yes, that's an embolization code. So you're going to bill the 61624. That's intracranial embolization. Okay. And if it's of the venous system, you got to use the venous codes. But typically that is, some are venous, but you will use the regular endovascular embolization code if you are doing that for a subdural hematoma or to limit the blood supply to a tumor pre-resection. You're going to build the embolization code, the 61624, and all the codes that go with it. The guidance code 75894, the follow-up codes, and if you did, and typically you would have done a diagnostic angiogram before, so you could determine which vessels you want to occlude. So you're going to build the diagnostic angiogram to identify what you're going to embolize, the embolization, and then the radiological supervision and interpretation for that. So you'd have at least 5 codes.
meningeal artery embolization, that's even though it's an extracranial vessel, it's intracranial embolization.
Absolutely, because the middle meningeal artery supplies the dura. Okay, so it is by what it supplies intracranial. So don't build a 61626. No, no, no. Middle meningeal supplies the dura. We're going to build a 61624. And oftentimes it is the middle meningeal that we're occluding for a subdural hematoma chronically, for example. That's going to be a 61624. It's not an extracranial vessel. It is technically, but it supplies the dura, which is cranial. And that's a very good question because that's often mistaken as the lower valued code, the 61626. The only time we use the 61626 is really for intractable nosebleeds or other things that are not intracranial, a glomus tumor, for example. Yes. Yes. Yeah, that's the tumor, the pituitary tumor resection without using an endoscope. So that's going transnasal, transsphenoidal, no endoscope. Yes, it is, because you use the endoscope to get there, and that's when you would use an ENT as co-surgeon. Well, either one of you use an ENT for co-surgeon, you can put a 62 modifier. One is not doing it neuroendoscopically, just doing it transnasal, transsphenoidal to get to and resect the pituitary tumor. The other one, 61548, is endoscopic transnasal, transsphenoidal, specifically for a pituitary tumor. Okay. And what's your approach? Craniotomy? The rule of thumb is one exposure, one code. Okay, whether that's an aneurysm, an AVM, a tumor. So it's by exposure. So if there are two tumors, maybe you've got a bifrontal craniotomy, there's two tumors, it's going to be one code, one exposure, one code. If it's an excessive amount of time and it took you 30 minutes longer or whatever to get that other tumor, that's a good reason to put a 22 modifier on the one tumor resection code. So anything you get with one exposure, you've got to pick one code, the highest valued code. And with an aneurysm, if it's ruptured, you often have to go through a hematoma. That's never separately billable. The hematoma is part of the ruptured aneurysm. There's no code for ruptured aneurysm. It's valued to include any blood you've got to evacuate to get to the aneurysm and treat it. You're only going to bill the aneurysm code. And with endovascular, if you've got more than one aneurysm that you're clipping in the same surgical field, it's one aneurysm code. There could be two aneurysms, but if you could have gotten those two aneurysms with the same craniotomy exposure, it's one surgical field, and that's going to be 1611624. It's not by aneurysms, either endovascularly or with a craniotomy. It's by surgical field. In an open code, it's by a craniotomy. In endovascular, it's by what you would have been able to get through one craniotomy. And that nosebleed example is, even though in nosebleeds, you may not get these here in an academic center, but if you do, we take two catheters up and we embolize both maxillary arteries. It's still one code, because if you were going to do that open, it'd be one exposure, right? So even if we have two catheters going up, and it's still going to be 161624. It's by surgical field. One code, one code. One exposure, one code. That's the rule of thumb. One bone flap, and you get everything done in that one bone flap, one code. Now, the exception, anybody doing peds? Sometimes with peds, with neuroendoscopic codes, there might be a little more flexibility. If you can get two separate and distinct pathologies through one burr hole, that's possible. We'd give a little bit of flexibility there and might bill two. So peds are a little bit different because you can get more with one burr hole. If it's an adult with one burr hole, neuroendoscopic, it's going to be one code. With peds, we look a little more carefully at what you did, and if it was two distinct pathologies that you're getting through one neuroendoscopic approach, I'd be more flexible and maybe give both codes.
This ETE and grid, adding on the grid categorization for our kids under 2 is one of our most common.
Yeah, I can't do the math. I have terrible here. So
That's this cauterization. Is there any push to get an actual code for endoscopic or because there is none.
we were talking about this, yeah. No, there's no push right now. And so that will be an unlisted code, okay? Unfortunately, okay? And as we mentioned earlier, unfortunately, it's not as easy as we'd hope there'd be lots of codes for all the new things that you guys are doing, especially in academic centers, but anywhere. But whenever a new code is considered, they have to consider what the ramifications would be with trying to get a new code, because we're so symbiotically or parasitically linked with Medicare. Whenever we want a new code, Medicare takes advantage of that request, and they'll take any other codes in the same code set or near that code, and they'll evaluate all. And they might give you a new code, but the result they'll reduce the value on all the other codes that are similar in the same code series. So eventually we'll lose money because they take the opportunity to reduce payment. And the reason they want to reduce payment is that most of our codes that are currently in effect have inpatient days and outpatient days. And maybe not in peds, but in other areas, patients go home sooner than they would have when the codes were developed. So all the codes have inpatient days and outpatient days embedded in them that Medicare is paying for, your private payers are paying for. So they love to get their hands on a series of codes, because then they can look at them and say, wait a minute, these patients go home in 2 days instead of 7 days in the hospital. So we're going to reduce payment on all those codes. We'll give you that new code, but it's going to reduce all the payment on codes that are similar, and then everybody loses.
Can we also code the open CPC code with a down modifier?
No, absolutely not. So unfortunately, there is no flexibility between open and endoscopic. Approaches are sacrosanct, okay? If you do something open that only has a PERT code, you have to use unlisted. If you do something open that only has an open code and you're doing it endoscopically, has to go unlisted, because we can't put a reduced service code. We didn't do less, we did different. So whenever we do different, and if approach is different, that's not reduced service, that's a different approach, has to go unlisted.
It sounds like that takes way longer than the ETV.
It totally, and the same thing has occurred in general surgery. Laparoscopic things take longer than the open codes very often. And there's not a lot of laparoscopic codes. So we compare them to the open code, but we say it's more difficult, more time consuming, more intense because it's done endoscopically or done laparoscopically. So we add to our request for payment based on our argument that based on the clinical work, it is 25% more difficult than the open code would have been. And we try to then say, we've set our fee at 25% in addition because it is more difficult. But if you're going to get paid for an unlisted code with more difficulty than the comp code, you as the surgeon have to help your coders and make a few comments that say, why is it more difficult? What about the technique makes it more difficult, more time consuming? That goes into their letter for the unlisted code and will enhance your chances of getting that paid more by 100%, okay? But they don't know that because they're not clinical. So you've got to give them that verbiage that says, why is it 30% more difficult than the open code? Yes.
There's an approach and there's a compare. We use that together, or do we use, is it like approach and tumor section?
There's an approach, that's the exposure, and then there's the tumor resection, and it has to be a tumor, can't be aneurysm, can't be CP angle. So we got two. Yeah, so let's say the same thing. So let's say the ENT, if the ENT exposes it for you, so it's in their area of expertise, they open it up, they do the exposure, and they're all done, they will build the exposure all by themselves. Conversely, if you go in and say, wait, I've got to extend the exposure because I'm now in my area of expertise and I'm going to extend that that exposure more into the cranium, then you share the exposure. So you and the ENT would have a 62 modifier on the exposure. Then if you go in and you do the entire tumor resection, you're going to build that tumor resection all by yourself, no modifiers. However, if part of that tumor is wrapped around something that the ENT handles and he or she does that for you, then you're co-surgeons on the tumor resection. So it depends on who does what and how well you document it. You could each take your own. If it's a clean exposure by the ENT, a clean tumor resection by you, and nobody overlaps, you're going to build those individual codes, and that's fine. You'll each get paid 100% for those codes. If there's any interrelated work, either on the approach or the resection, then you're co-surgeon on both or one. Is that clear, or did I confuse you more?
I don't know what the, it's not mostly so that.
Yes, there is, I'm not sure there's not a cranial encephalocele code. No, I'm going to look into that, but there's no actual cranial code. Is this in peds or adults? Okay. So let me think about that. There's not a code that I can think of offhand that's for an encephalo. Now, is this just a CSF collection? Okay, so that might be, there are codes for a herniation. Is it posterior? Okay, I'd have to look at that. It's possible that that could be, there are a couple codes for herniation that aren't a Chiari that might apply to those. So I'll look into those and I'll let Nansa and Serge know what those might be. If you can find one, I don't know one offhand for that, but I can look and get back to Nance.
I don't think it would be carried because the private is very different.
Yeah, Chiari is a different, but so you're just,
There's not a suboccipital compression. There's only that for care. We used to say one is the same.
no, there's another suboccipital decompression that's right under the 61343 for Chiari. There's other posterior fossa decompression. I think it's 61344, and that would apply to that. So there's the Chiari decompression posterior fossa, and there's one right under it for decompression of the posterior fossa. I think it's 61344. If you're looking at that, Nansa. Okay. And that's for other than Chiari. And remember, the Chiari key says EG. And in the world of CPT, lexicon, EG means, for example. It's not the only pathology that applies to that code. But there is another decompression code of the posterior fossa right under that code. And IE means you can only use this code for this pathology. EG means, here's an example, it's the most common thing done, but there might be other things that could also be decompressed posteriorly. But in this case, there is another code. If you can look at that, 613, it's right under the Chiari code.
No,
In Cerna, yeah. And sometimes, the Cerna may not have absolutely everything in there, unfortunately, especially things that you do that are maybe unusual as an academic center. There might be some. So then you'd have to, is there any option in Cerner to add in something that's not in their list of procedures? Yeah. Of course. And then you may want to just email Sergi and say, is there a code for this? Did you find that 613? There's one right under 61343, which is the Chiari, I believe, for other decompression posterior fossa. So yes, sometimes they don't put all the codes in because as an academic center, you might do more. You can certainly ask them to add a code if it's something that you do more routinely. And I know it takes forever to get the data set up and the coding set up for another code, but it's certainly possible they could put that in. You have a CPT manual? Okay, no. So I don't carry my CPT manual with me at all times. But I will let Nancy know that and get it to you, but there is a code right under the Chiari code that would apply for that. And whenever I can, now, in the old days when I was younger and had to be strict and conservative, I was really stuck to unlisted if it doesn't describe, and I'm still that way. If it doesn't describe what you did, we have to go unlisted. But I want to try to make sure unlisted codes, because payers do not want to pay you. Understand that as an underlying concept. They do not want to pay you, okay? So they do everything they can to not pay you. So I try to find whatever code I think would be the most supportable code. And if your documentation supported that posterior decompression for a different pathology, I would definitely use that instead of an unlisted code, because that's going to get you paid. Payers look at unlisted codes, and I've had some payers say, we don't pay for unlisted codes. How dare they? Unlisted codes are part of the world because we don't have codes for all of the things you do that are new, that are different, and we have to use unlisted codes. But payers, because they have the power and we don't, they can just arbitrarily say, we decided we're not paying for unlisted codes. What? Okay. Or they say, we don't pay for category 3, but that's different. But they just arbitrarily say, we don't pay for unlisted codes, which is something you as an academic institution should fight. And if you have to, get surgeons to come in and talk to the medical director of the payer and say, we'd like to discuss this. Unlisted codes are the way of the world in an academic center and others, and there must be some approach and some mechanism for us to get paid for unlisted codes. Let's talk. Okay. But if we don't go that far, if we don't get our doctors involved with the medical directors, God forbid, I hate to, have any one of your doctors have to talk to a medical director of a payer, because as you can imagine, it's brutal. Okay. And they come out of there like they just were in Fight Club, but in some cases, we have to elevate and have a surgeon with a consistent problem. If they keep telling you, we're never paying for unlisted codes, that's a time where you've got to get your surgeons involved, find out who the medical director of that payer is, and get your surgeons to get a meeting with that payer and say, we'd like to talk about this, okay? Because sometimes you're going to have to elevate it to that level. Thank you. Any other questions? Are you guys residents or surgeons? You're residents? Okay. You're going to really need this because, to get your boards, you have to answer coding questions now. Do you know that? Did you know that, guys? Okay. You're the only surgical specialty out there whose boards have now included coding questions. So be ready. Okay. And those will be on your boards. Good luck. Thank you, guys.